Hello, everyone. Welcome to another Tuesday with the Ravi and the CPS Solvers team. Today, we are going to do a little bit different. Ravi will be presenting a case for us, and we'll have a little bit of POCUS we continue learning some POCUS, which we are super POCUS enthusiastic, and I will be discussing with Yes. Yes, how are you today?
Oh, I'm good, Deb. I'm very good. Thank you for asking. How are you, Dr. Ravi? I'm looking forward for POCUS. Like I have to say that these VMRs help a lot, and I can wait to see what everybody says in the chat.
Oh, great to have both of you on. I'm just so pleased that on CPS we're able to do new and innovative things. And last year we started to do point of care ultrasound, including that into the video monitoring reports to both teach people that aren't familiar with point of care ultrasound and also to sort of add a new layer of education to VMR. We also take pride in our ability to have our team members take on the task of facilitating. So today I'm going to take the back seat and bring a case and then just bask in the glory of Deborah and Yasmin's discussion today. So very excited to see you both tackle this case.
Amazing. Should we get started with the whiteboard?
Here we go. Okay, so the first aliquot, we have a 56-year-old female, and she comes to the emergency room with a complaint of 10 out of 10 pain in the left foot and leg. There's also numbness and swelling, which started ramping up over 7 days, and I'll stop there.
Oh, that is interesting. Like thinking about the foot pain, like I like to start, could be this pain like from the muscle, from the vessels, could be like some innervation, something. What could be happening in that area? Like make me think like going like from an anatomic way, and associated with numbness and swelling, make me think something neuro, like could be happening, something maybe going out for other causes, maybe diabetes. And yeah, I would like to know more about this. How long time is out for 7 days? No, you said. How was before? How was the foot before the patient? If it is in the tube or is just one side? What do you think? Yes.
I am right there with you, my friend. I think that when we're talking about a unilateral foot pain, and it's also like extending to the leg, the first approach can be an anatomic to think, is there an issue vascular? Is it an issue with the lymph nodes? Is there an issue with the muscles, even bones? I would ask this person if she has diabetes, if I don't remember if it's a female, if she has diabetes, if she has an ulcer, that I think the physical exploration would be very important in this case if she were to have that past medical history. And when I'm talking about a swelling, lower extremity edema, when it's unilateral, we can think about cellulitis, COMP syndrome, neuropathy, foot drop, May-Thurner, and many of them can be acute unilateral causes, such as DVT, such as cellulitis, rupture. Those are like having this onset and being able to localize ourselves on time can help us like discard some diagnosis from the beginning. But yeah, that's basically my approach.
Brilliant, the both of you. Yeah, short and to the point. And I think both of you have concerns that a lot of people in the chat are also interested in learning about. So a few more details that the chat would like to know. So initially, this patient does have a history of peripheral artery disease, but for the past 7 days, she was doing relatively well, just feeling some pain in the upper part of the leg, went to a primary care physician and was told possibly sciatica and then to return back if it was not resolving. And then she began to feel pins and needles, and intermittently until it got constant and worse. And then this pain came about. So it's a dull, aching pain. She's also started to have fevers for the last 2 days and denies any dyspnea or chest pain. And I'll wait till the scribe catches up. Yep. And I'll add in the past medical history: diabetes mellitus type 2, hyperlipidemia, hypertension, peripheral artery disease I mentioned, and coronary artery disease. Has had 2 stents placed. Surgery, left and right axillobifemoral bypass 2 years ago. And medications, metoprolol, losartan, aspirin, apixaban, statin, insulin, and gabapentin. And she's also a smoker for smoking history of 30 years. And we'll stop there for discussion.
Do you want to start, Yes?
Oh, of course, of course. When I hear about pins and needles, I'm thinking paresthesias. And when I listen to paresthesias, the peripheral neuropathy can be, as Dr. Berkowitz has shown us before, can be usually sensory or axonal, and according to the etiologies is the way that they're going to present. Now, in this case, taking the whole picture together, this person has diabetes mellitus, she smokes, she has like vascular issues, she had bypass. I'm thinking her risk for DVT can be high. Another note, the fever also makes me add into this differential diagnosis. Could this be infectious? Again, I will definitely be looking into that, but looking for ulcers, looking for any kind of like entrance of any pathogen. But going back to peripheral neuropathy, other things that can cause it can be toxic, can be metabolic, can be infectious, can be neuropathic, neurologic, sorry. And now situating myself in infectious disease could be bacterial infection, Lyme disease can cause it, leprosy can cause it. Of course, we're not in the geographic area, but just because I like talking about ID. And there are other deficiencies such as B12 and B6 deficiencies. We can talk about other endocrinology issues such as hypothyroidism. This person has diabetes mellitus type 2. It's not really associated with this one, but it's something that we would like to add in the workup, TSH maybe. But yeah, those are my first diagnosis. And a shout out to Shreyas, because I always love to read his diagnosis in the chat. What do you think, friend?
Yeah, like you said about the diagnosis of Shreyas, but you didn't tell what he said. Like he put the differential diagnosis first: diabetic neuropathy. Number 2, infection, tinea cellulitis. Number 3, venous insufficient. And number 4, acute limb ischemia. Just perfect. And like completing what you said, I think this patient has a really important past medical history, like for having vascular problems in the feet, having like a neuropathy problem in the feet, and all that could be related. And looking at diabetes make me think like if the patient controls well this diabetes, if doesn't control well, because that can definitely affect the feet. And adding to that, the patient has like a history for smoking, that can also like can increase the risk for something in the vascular, in the lower extremity. So yeah, like as the patient has fever, I will be looking for the vitals and do like a really good physical exam and see how is this feet. Back to you, Ravi.
Awesome discussion, both of you, and you pretty much nailed the emergency diagnosis there. So moving on to physical exam, starting with the vital signs, temperature 38.9. Heart rate 98. Blood pressure 200 over 100. Respiratory rate 22. Oxygen 96%. Room air. And to cut to the chase, generally she was looking toxic, not well. And then extremities, left leg, it's cold, pale, hairless, no sensation from mid-calf to the lower part of the leg. Unable to move toes and ankle. Unable to feel the pulses. And the leg is massively swollen compared to the right. And just moving the leg is eliciting screaming pain. The right leg is not swollen, but is also cool. Pulses obtainable by Doppler. And there's no pain in comparison to the left. And we'll stop there.
Yeah, like looking for these vitals and physical exam, I always like to think, is this patient sick or not sick? And we definitely see a sick patient here. We see a patient with fever, with this elevated blood pressure, elevated respiratory rate, this saturation 96%, make me think that as she has like a history of smoking, maybe she has some COPD, and then she like has like this respiratory that has this saturation. And looking for the leg, like I start to be concerned because she's having a lot of pain and it's not able to feel, and make me think like it could be like something from orthopedics, like I don't know, a compartmental syndrome. I don't remember on details. Do you remember? Yes.
Yeah, actually, yeah, you were right there, my friend. You're doing very good. This cold, pale left leg with an excruciating pain situate us in compartment syndrome. Definitely, that's the first thing that everybody has to have. Like whenever you go into your rounds and you see a person that has a very excruciating pain out of proportion, think about compartment syndrome. This person has paresthesia. She has sensory deficits. She cannot move the leg. Well, like she cannot move her toes and ankle, and we cannot feel the pulses. So for me, this is compartment syndrome until proven otherwise. That will be my first thought, because we're thinking that if we have around like 6 hours of ischemia, that foot can be compromised, and that's what we have to avoid. Now, this is of course a POCUS, so I'm thinking that we'll be looking at the arterial and venous and all the tissues, but before jumping into that, that's my first thought.
All right, let me give you some labs. So very good discussion. I think everybody's suspicions for an emergency is high, which it should be. And definitely this is not a diagnosis you want to meet at the middle of the night on a night float shift, but something that you must be prepared for. Mark can probably tell you that he's shaking his head. So labs, his CPK, her CPK is 293, white cell count 15, hemoglobin 12. Platelet count 334. Lactate is 3.7. And creatinine was normal, as asked in the chat. Bicarb 17 and UNGAP 15. And then I'll let you think about the labs, and then I'll bring up some POCUS images.
Do you want to go? Yes.
Of course. For me, I'm listening. This is a high lactate, more than 1 millimole, I think, if I'm not wrong. This is a high lactate. So I'm thinking this person is like, all those, please correct me if I'm wrong, it's better to have procalcitonin instead of lactate to see if this person is septic. But I'm thinking there is an acute process, there is an infection. Could this be an infection caused compartment syndrome? There's a high CPK too. So I'm not sure if this is because the muscle is being damaged, and that's why we're having this CPK. So these two main markers are telling me that this person, her leg is already ischemic and it's already being compromised, and we have to act quickly because its CPK is high, and as well as the lactate. So yeah, what that's my first shot. Oh, and the WBCs are 15. So yeah, definitely thinking of something infectious. What do you think, Deb?
Yeah, I'm thinking the same as you, like the patient has like an elevated white blood cells, and this lactate definitely talk like it could be like a septic shock maybe, and I am concerned about this patient. So as we are in a POCUS, like maybe we could do like try to get some imaging to see how is this leg, how is the feet, to discover what is happening with the patient.
Okay, I'm gonna share some POCUS or show how POCUS can kind of help in this kind of a condition. Let me. Give me a second. Trying to share the screen. Okay, I fixed it. Let me share it now. It wasn't giving me the whole screen. Can you see now? Let me get rid of the. For some reason it's not showing. Can you see the pictures now?
Yeah, completely. We can see how
Oh,
it
okay, good,
and everything.
good. So for some reason, it was doing some presenter view. So here, point of care ultrasound, taking the left leg and externally rotating it. I don't know if you can see my pointer. Let me swap the displays. Like, can you see it now?
We can see your pointer.
Oh, you see it now?
We were seeing before too.
All right, now.
Yes. Yeah, we can see.
Okay. So the common femoral vein, when you place the probe here, you have to put it in the vascular view. And here, when you put it in the common femoral vein, there's going to be 3 stations where you will apply the probe, and you will then see the artery and the vein together. And the whole theory behind doing venous Doppler or venous ultrasound, especially using point of care ultrasound, is the ability to compress the vein. So the vein is devoid of any thrombus or any echogenic structure. So here you can see the vein, the deep veins follow the artery, and at the common femoral vein, you'll see the common femoral vein and common femoral artery, like depicted here in this box here. This is pretty easy to do. It doesn't take much practice, and you can pick it up within an hour. It's just moving the probe or orienting the probe in a transverse in a transverse manner to get this field of image here. So here, what you're seeing is lack of compressibility of the clot here, and or of the vein here, and usually it's compressible. So if you ever see a Doppler report, they tend to write that there's compressibility or lack of compressibility. When there's lack of compressibility, there is something within the clot not allowing for compressibility, which is this clot. Usually a clot is difficult to see. As it becomes organized, it will become echogenic. So it goes from sort of a hypoechoic to now you're seeing it's a gray, sort of mirroring some of the surrounding structures. So a isoechoic image here. So there's a clot in the common femoral vein. Then moving on, common femoral vein with the takeoff of the saphenous vein, and we get this almost like Mickey Mouse appearance, 2 ears and then the face. And here you're seeing again clot. There's echogenicity here, and in the takeoff of the saphenous vein, and the artery is accompanying it. You can also do Doppler to see phasic like flow to see. So within the vein, you won't see any flow. And remember, the different colors, you get blue and red as well. And I have an image in the next one. So here we're going down now to the femoral vein, and we're seeing the femoral artery and the femoral vein here. And we see flow within the femoral artery, but we're seeing no flow within the femoral vein. So again, we're seeing this echogenic structure. This is normal here. So here we're seeing, we're seeing the clot here and lack of compressibility. And here again, lack of compressibility. But if we deploy Doppler, the setting, then we're able to see that there's at least some flow within the artery, but we're not seeing any flow within the vein. And then the next station would be the popliteal vein here. And we see the popliteal vein is above and the artery below. And here we're seeing lack of compressibility in the vein, and the artery is below. So there's extensive clot all the way from the common femoral vein down to the popliteal vein and the tributaries. So this is concerning. So there is a DVT, which is quite extensive. So now incorporating that into this patient's presentation, any thoughts, or what would you do at this step?
Do you want to answer? Yes.
Oh, yeah, of course. For her, I will definitely think about reperfusion as a because cold empiric, we don't know how much time this clot has been there. And again, 4 to 6 hours of ischemia can compromise this limb. Now I will think of maybe surgical, or and evaluate if this patient is candidate for anticoagulation, because there are also like and also like look for where is the thrombus, like why is this person creating thrombus? Is she creating thrombus because of an infectious process? Does she has an hypercoagulable state? Is there any other issue? And if she's candidate to anticoagulate, medical therapy or a filter to avoid this thrombus to go somewhere else. So yeah, that would be basically page surgery. So that would be my next step. Evaluate where the thrombus is. Why is this person creating thrombus? And take care of that, and evaluate if she's a candidate for anticoagulation. If not, that will be think about a filter or something like that. Those are my 3 points.
Yeah, like I was thinking, like with the medications that this patient have, like apixaban and aspirin, why we still have this DVT, extensive DVT? So I'm thinking the patient is really taking the medication. What could be happening? I don't know, the patient. I don't know. I'm thinking about this medication right now. And even like if the patient was sick for a long time or passed for surgery or something like that, the medication should like prevent for something like that to happen. So yeah, like as it's so extensive, I will definitely see with surgery, like to look for the best option. And Ravi, you was started antibiotics on this patient with this white BC?
Yes, exactly here. So antibiotics were started, but what would you like to do? What was the first thing you would like to do? Sorry, I was getting texts about some emergency to cover at work.
Hey, vascular, definitely.
Vascular. Okay, I did hear that. So
yeah, I'm so sorry. I think I just skipped on that. But yeah, like completely agree with that. Page vascular to determine if like how to reperfuse this limb, and then think, is this person candidate for a medical anticoagulation or a filter? Because I've seen that before, especially like I think I've seen it with your patients. And basically this, and look then why this person is making thrombus.
Absolutely wonderful. Yeah. So, go ahead, Deborah.
No, I was wondering, like, if the patient is taking apixaban and aspirin, why has this so extensive DVT? If the patient is really taking, I was wondering about that.
Yeah, that's a good question. Yeah. If you develop a clot on top of anticoagulation, is that the right treatment, or is there something else that's going on in the background? So the next aliquot, I think there's one more aliquot before, but you'll get the idea. But then what you'll have to do is think about what is going on and how best to address this. So the point ultrasound showed this venous clot. During this time, this leg is getting worse. Now it's cyanotic. And arterial formal, every time you do a point ultrasound, you want to get a formal image just to back up your findings, because we're not radiologists, and we do need to get an official documented report. So vascular surgery is there because she has extensive peripheral artery disease. They obtain a formal venous and also arterial ultrasound, because with the thrombus, why is she having such like feeble pulses? And also now the leg is cyanotic and now also cold. And they do find this extensive clot from the common femoral vein to the greater saphenous vein to the popliteal, and also occlusive left common femoral artery thrombosis. CT angio shows gas in the left thrombosed proximal axillary femoral bypass graft. And they're considering doing surgery. So now you have both arterial and venous clots. And during this time, this patient is declining. White cell count is going up to 20,000. Lactate is 7. And I will stop there. And then I will disclose what then happens.
Yes. What is happening with this patient?
I heard gas, and I'm thinking there is something metabolizing causing this gas, and that something is above. Like for me, I listen to gas, and there is a bacteria. I'm sorry for everybody that doesn't like listening people calling bacteria bugs, but that's a way. And the first thing I remember, even Dr. Andrew presented once, he's here, a case of gas gangrene, and thinking, could now that our next yeah, definitely NAPRIC, Clostridium perfringens, thinking about specifically of this finding of gas in the imaging on the exploration. So this person has fever, this person has she's looking toxic, she has an excruciating pain of a rapid onset. This could be the cause. And since she had this coronary arterial disease, 2 stents, she has a risk factor. Now, that will be my first thought, like this bacteria. But also there are like staph, there are other, how do you say, like pathogens, but those are my first ones. Yes, mentioned, Elena has also mentioned group A strep, Staph aureus, Vibrio vulnificus, but yeah, those are my first, like Clostridium perfringens is my first suspect. Aseptic thrombophlebitis. And then again, we're thinking what came first, egg of the chicken, if the thrombophlebitis was first and then it caused an extensive DVT, or was this hypercoagulable state like a petri dish for this bug? So yeah, it's interesting, definitely needing stress control.
Yeah, like definitely make me think of Clostridium perfringens. I hope I'm saying right. And I would be extremely concerned because the patient is getting worse. White BC, WBC, it's getting high, lactated. I would definitely like consult ID to check if these antibiotics could be for the situation or not, like changing the medication. I'm thinking what else I would do. Yeah, but maybe a culture, a blood culture to see what is happening. What do you do? Yes.
Yeah, you're completely right, friend. Blood culture will be to find out if this patient has what kind of bacteria we're talking about. Somebody correct me if I'm wrong. I think the antibiotics that we can give if we're thinking Clostridium could be a penicillin plus clindamycin or even a tetracycline. But then again, those will be like my first. And yes, sometimes we have to wait to the result of the cultures, but we can start empiric antibiotic therapy, specifically because this person has, like, it's really bad. Like, I am wondering if this person will have to go through an amputation because we have already vital signs like fever, hypertension, she's looking toxic. We don't have pulses. She can't move the leg. So those are the antibiotics I would start with. Yeah.
Awesome. POCUS and ID. Yasmin, you didn't know ID would be part of this case, so I can see you getting very, very excited. But absolutely, you're spot on. You're dealing with possible neck fascia. You want to cover polymicrobial infection. So having the gram-positive cocciso anti-MRSA agents, vancomycin, probably linezolid, daptomycin, and then also adding gram-negative pseudomonal coverage, and then clindamycin. So you could do vancomycin and clindamycin, or vancomycin and clindamycin, or vancomycin plus anaerobic coverage, metronidazole plus clindamycin. Although clindamycin does cover anaerobes, so you could negate that metronidazole. So yeah, the vancomycin and clinda started, and this patient is now taken to surgery and was found to have extensive muscle and fascia necrosis, fat necrosis, and had to go a high above the knee amputation, started on aspirin, Plavix, heparin, and intraoperative cultures found growth of MRSA, Enterococcus proteus. So that's covered appropriately with these antibiotics. And I guess I'll stop there. We have some time. Do you want to probably munch or chew on this information before I give you the final diagnosis?
Nothing. I'm trying to think everything. It's a lot of information. So yeah, like unfortunately the patient had to pass for amputation and then had the blood culture. Like it's good, like that the patient had like positive for some bacteria. But now thinking about the final diagnosis, I don't know. What do you think, Yes?
Like, I would definitely want to know where this person got the MRSA from. Like, I'm thinking, what risk factors? She's 56. She's not that old. She has the only risk factor of where could this bacteria have come from is the stents, but they mentioned that it was 2 years ago. So I'm thinking when I see MRSA is like if this person has chronic diseases, if this person has any kind of immunosuppression, I'm guessing diabetes mellitus to see if the next thing, like the follow-up will be like primary care practitioner, take care of his diabetes, like if she has an uncontrolled diabetes mellitus. Also, if she has malnutrition, if she smokes, because also like an impaired airway protection is like a way to get MRSA like places. So anything, if the patient had dysphagia, smoking, if she had any other infection previously, and of course other environmental factors will be a crowded living condition, how she's living, if she's exposed to contaminated water systems, if she has other zoonotic exposures, like just thinking about like where did she get this MRSA. But that will be it. That will be like a task for the follow-up primary care practitioner, I guess. But yeah, there are many reasons that we have to be very, I mean, for me, I will go to where did it came from? Where does it go? So,
Yeah, that's a great thought. Actually, this patient has a lot of risk factors. But the question is, these risk factors explain everything, or the patient has something else like happening? That's a good question. So yeah, Ravi, tell us what happened.
Absolutely amazing. Yeah, it's you definitely got the emergency part of this, and also getting the consults, which is very important in a timely manner, surgery, and also getting ID involved too, because of the complex nature of this infection. And MRSA, yeah, why is this patient having MRSA? I guess repeated meetings with the healthcare industry, possibly pre-surgical prophylaxis, getting conventional antibiotics, and also people highlighting in the chat diabetes. So the case is interesting because they're both venous and thrombosis, venous and arterial, sorry. So it appeared that she was not taking her Eliquis or had run out of her Eliquis. So she was without her Eliquis. All testing, so at a young age, having such a high clot burden, then we have to start thinking about people thinking about autoimmune disease, APLAS, and so on, and then all these prothrombotic states. So those actually will need to be worked up. Currently maintained on heparin. And this is sort of, it's difficult to say, is it phlegmasia and plus acute limb ischemia? I would say kind of with the amount of swelling, I think phlegmasia definitely is relevant in this case. And people initially had highlighted that along with acute limb ischemia from the arterial clot. We checked COVID as well, because during COVID, we did see a lot of people with both arterial and venous clots presenting, and then also paradoxical emboli, so echo to make sure there's no PFO for a paradoxical emboli occurring, so DVT going to the arterial side. that was also checked and was negative. Luckily, there was no PE in the patient, so no respiratory decompensation that would indicate PE. But these patients are very high risk for PE as well. Somebody also mentioned May-Thurner syndrome because it was the left leg. That would be the compression of the left common iliac vein between the lumbar spine and right common iliac artery. So that would be also something interesting. So I'm not sure exactly which part of the spectrum, if this was phlegmasia, cerulean-Dolan's, or if this was just a massive thrombosis, and also patient was non-compliant with her medications. But it was definitely life-threatening, and like Mark was shaking his head, this is something you do not want to be called in the middle of the night when there's a lack of hands on deck, and this is an emergency. But it's very important not to go to sleep on this, but to get this taken care of. Unfortunately, the clot burden was so massive that the patient already did have peripheral vascular disease and ended up having to lose part of the leg. But it was like loss of limb or loss of life in that case. So wonderful discussion, both of you, and definitely something, once you do enter medical training, it's something you will encounter, and you absolutely have the knowledge and the ability to tackle such an emergency. Thank you.
Amazing, Ravi. Thank you so much for presenting us. It was a really great case. Was nice to see some images of the POCUS, and yeah, like we are always learning POCUS with you, so I really appreciate it. And thank you, Yas, for discussing with me today. Do you have any final thoughts, Amiga?
Just thinking, like, whenever you see a patient like this, I just saw this once on my internship in Mexico, and that was enough for me to know that if you don't do the workup quickly, the person ends up losing a leg. So, and yeah, thank you so much, Dr. Ravi. This ended up being a POCUS ID vascular, but mainly ID. So I'm very, very happy. Thank you.
I think we can go now for the teaching points. English, please.
All right, thank you guys. That was an amazing case and reminds me of step 2, phlegmasia cerulean Dolan, something I learned in step 2, and quite a scary entity and a result of massive thrombosis. So that was a very interesting case. And this is my first POCUS case with Dr. Ravi, and I was really excited, and I'm glad that I'm going to be doing teaching points. So let's get started with the problem representation. So we have a 56-year-old female who has a past medical history significant for diabetes, hypertension, hyperlipidemia, coronary artery disease, peripheral artery disease, and then she underwent bilateral axial bifemoral bypass, if I'm not wrong. And then she also has a really long-term history of smoking. And then she presents in the ED with acute onset of leg pain, swelling, cyanosis, and systemic signs of infection. And the fact that the way the limb presented was basically all of the signs of vascular insufficiency, the hair loss and the coldness, right? And then the symptoms were more prominent on the right as compared to the left. So then moving forward, I'm going to first talk about in such a case, how do you proceed? So with this kind of a presentation, you want to dive deeper into the history, and you want to align your thought process and kind of differentiate how critical the situation is. So you want to differentiate between a neuropathy versus a vascular phenomena. All of us were aligned towards acute limb ischemia. And when you think of acute limb ischemia, the easiest way to diagnose is to keep in mind the 6 Ps, which include pain, pallor, poikiloothermia, which was coldness of the extremities, pulselessness, paresthesias, and paralysis. And I believe we had all of these 6 Ps in this patient. And then the high lactate, the fever, the increased WBC counts are kind of making us think of a septic situation, and this patient did look toxic. So we were leaning towards septic shock and, severe ischemia. And then comes in the POCUS, the new hot topic for all physicians. So the POCUS that Dr. Ravi revealed had some very interesting findings. So you want to be able to compare normal POCUS findings and kind of see and keep in mind a few points. The 2 points that for me were the most prominent take-home points today were the compressibility, right? So if there is if there is lack of compression, it is the most sensitive indicator of a DVT. And then the collapsibility, right? If there is absence of collapsibility, obviously there is something occluding the vessel, which is not allowing it to collapse. I hope I'm not going too fast. But then, so to dive deeper into it, we wanted further radiological evidence. So we went with arterial and venous ultrasounds, and we saw that there was an extensive DVT going from the femoral vein all the way down to the peripheral, tributaries. And then further investigations revealed that this patient had gas in the bypass graft, which then made us all think of myonecrosis and then gas-producing bacteria like Clostridium perfringens. And then since this patient is a diabetic, we want to think of polymicrobial infections. And eventually, the cultures did reveal multiple bacteria. And, then we want to start in such a patient, very important to provide critical and symptomatic care, which includes broad spectrum antibiotic coverage, and we want to make sure we're covering gram-positive, negative, and we're covering the anaerobes as well. So we started this patient on VANC, which also covered MRSA, and this patient did have growth of MRSA as well as enterococci. And then a very important thing is you want to rush these patients to surgery, because with that extensive of a clot, you don't want to these patients can end up having to compromise their limbs. And this patient did undergo an above knee amputation, and that was the right approach to involve all the teams and kind of go in a sort of from most acute and most immediate, kind of care to, the least important one. And another thing to keep in mind is you want to start anticoagulation. You want to do the risk assessment for these patients. And so this patient ended up compromising their limb, and we did the antibiotic coverage. We did whatever we could. And then in the end, the very interesting entity, which was a suspected or a possible diagnosis, was Pygmasia cerulea dolens, which is a very serious complication of massive DVT. And the fact that this patient had cyanosis and the discoloration and the swelling and the severity of the situation kind of makes us lean more towards Pygmasia. And then we did have the massive thrombosis. I hope I covered most of the points.
Amazing. Thank you so much. You did so great. I'm super proud of you, and it was a pleasure to listen for you with these amazing teaching points. So yeah, thank you everyone for being with us today. I hope to see you all tomorrow. Bye-bye. Take care.